Prescribing medications for older adults. The objectives for this presentation are as follows. We will look at older adult and frailty and discuss the significance of these terms when prescribing. We'll discuss special prescribing considerations for older adults. We'll examine polypharmacy and medication assessment in older adults, including the prescribing cascade. And finally, we'll examine. Many terms are used to describe this age group: geriatric, elderly, seniors. It's important to remember that chronological age versus health age can be defined differently by different patients. You can have an 85-year-old person who's much healthier than the 60-year-old son or daughter that brought them to clinic. It reminds us that age is more than a number, it's a continuum. Despite this, however, we do need to keep the principles of prescribing in mind even more as age and frailty is defined as the progressive decline of multiple body symptoms. It's marked by loss of physiologic reserve and an increased risk of poor outcomes. Common signs are fatigue, weight loss, muscle weakness, and a decline in function that is progressive. This slide is a snapshot of the clinical frailty scale that was developed by Dr. Ken Rockwood and his team at Dalhousie University. It's a common tool. You may have seen it in practice with your preceptor already. The reference for this is at the end of the presentation, and I'd refer you to investigate this as well as the supporting evidence a little further. It's an invaluable tool to use when assessing your older adult patient. There are 5 special considerations when prescribing for older adults, and we'll look at each one of these separately. Physiological changes can impact the pharmacodynamics and pharmacokinetics of medication. So kidney function, changes in liver function, body water and fat distribution, body mass and muscle mass can impact the absorption, distribution, metabolism, and excretion of medications that are part of that pharmacokinetic process. Pharmacodynamic factors can change the sensitivity of certain drugs, so things like anticholinergic, benzodiazepines, opiates are all altered with age. Comorbidity and polypharmacy have a huge relationship. Modern medical science has enabled us to have people live longer and healthier with multiple comorbid diseases. But when you consider the collection of medications required for each single diagnosis, think about the numbers then when you have multiple comorbid diagnoses brought together. And this can increase that harm-benefit balance by interactions created between some of these different medications. Sometimes there's no ideal option, but it's a great time to involve a pharmacist or other members of your collaborative team to help with optimal decision making. What is polypharmacy? There's different definitions. Some people look purely at numbers, 5, 10, maybe 15. Other definitions look at polypharmacy as being more medications that are clinically indicated. So maybe one medication is polypharmacy if the person doesn't need any medication. It also can be considered the use of inappropriate medication. Polypharmacy itself increases the risk of drug-to-drug or drug-to-disease interactions and can create its own drug-induced problems. We often call this the prescribing cascade. So the prescribing cascade itself, it's when a new medication is prescribed to treat a symptoms that arise unrecognized as being part of a drug event rather than a new diagnosis. And then you start piling new medications on to deal with side effects that, again, are misinterpreted as a new diagnosis. So here are some of the common cascade medications. From this list, you'll recognize many that your older adult patient takes to manage their chronic illness and manage other symptoms. And here is an example of a prescribing cascade. Calcium channel blockers are used to manage hypertension, and they're very effective medication. But as you know, ankle swelling is one of the common side effects. So a patient presents with swollen ankles, perhaps they're given furosemide to deal with that ankle edema, the symptom, which is treated as a new diagnosis, but a side effect of the furosemide is low potassium. So to manage the low potassium, we give them a potassium replacement. So here's an example where two medications were added for presumed new diagnoses that were actually side effects of that original calcium channel blocker. Very important to do drug reviews. Life expectancy and time to benefit of a medication must also be considered. So if that time to benefit is equal to or longer than the patient's life expectancy, the drug is unlikely to be beneficial to the patient. Two common examples are shown here. Statins that are used to treat dyslipidemia and bisphosphonates, which are used to treat osteoporosis. Bisphosphonates actually have about a 10-year time to benefit window that, depending on the person's age, it may not be worth the risk and the quality of life. Again, circles back to the idea of harm versus benefit. Benzodiazepines are the example used here. When you think about the benefits that they provide versus the cognitive and falls risk created by their sedative effect, you may want to think of an alternative to help a person sleep. There also needs to be a shift from cure to comfort in an older adult patient. Their expectations may well be just comfort measures and symptom support, but that's an important conversation to have. And we need to also watch for those interventions that aren't any longer useful or desired, as this can impact quality of life. Finally, the patient's personal values need to be factored in when decisions are made, and that needs to be a shared process. The patient and caregiver's wishes, their view of health, their definition of health, and socioeconomic determinants are critical, especially when it comes down to things like financial stressors of old age. This quote's a great reminder for us. The task for clinicians not to determine whether too many or too few medications are being taken, but to determine if the patient is taking the right medication. Sort of points us away from the numbers. So as promised, here are one of the three strategies that I wanted to briefly draw your attention to use when prescribing. You may have heard of these. The stop and start criteria. These are acronyms that refer to criteria used to guide decision making about the most common and potentially dangerous inappropriate drugs used in older adults. The most recent update of this criteria is 2015, so it's relatively new. The references included in the list at the end of the presentation, and a second tool you may have heard of are the Beers criteria, first developed in 1991 by Dr. Mark Beers, who was a geriatrician. The Beers criteria identify medications that pose potential risks that outweigh potential benefits for people 65 and over, looking at what they call potentially inappropriate medications, or PIMS. The criteria help inform clinical decision making and improve safety and quality of care. They shouldn't supersede clinical judgment or patient's choices, but they are triggers to make us ask questions. This list is just a short list of the common Beers drugs. You see the middle three are actually known for their sedative properties, which can increase fall risk in an older adult. And the third strategy I wanted to talk about is deprescribing. This is the process of stopping, reducing, or slowly withdrawing medications. They are evidence supported, and I've provided some examples here. Some psychotropic drugs, cardiovascular drugs, even antipsychotics. By withdrawing these medications, we can reduce falls risk, improve cognition, or potentially reduced mortality in a dementia patient. The systematic approach for discontinuation of multiple medications in older adults, big name, it's a study that was done in 2010. There were 70 patients involved with a mean age of about 83. Each person was on average, about 8 medications. And when all of these drugs were reviewed, 58% of them, or 311, were recommended for discontinuation. 81% were subsequently successfully discontinued, and 88% of the patients participating reported feeling better after the drugs were stopped. So it's a good reminder that we need to be thinking about why people are being given all of these medications. When should you think about deprescribing? Well, on an annual basis for sure. Have the patient, we'll do a drug review with patients. We need to do a review of things if suddenly the patient experiences some type of an adverse drug reaction. We need to consider if polypharmacy cases are identified either by our own drug review or by a member of our team. If treatments seem or become ineffective, and this could be something the patient's been using for 10 or 15 years, age and changes that we discussed earlier could impact the effectiveness, so it's a good time to think, is it time to take this drug away? Advanced age, frailty, or changes in treatment goals are another good trigger to consider deprescribing. High-risk medications, we've mentioned them, benzodiazepines, opiates, things like that. They need to be considered as well, and perhaps that weaning, even cutting the dose in half might be beneficial, and that's part of deprescribing. Finally, if patients are having falls or cognitive impairment is being noted, that's a good trigger also to have discussions about changing, reducing some of the medication. Some of the barriers you may encounter are concerns by the patients or their caregivers about reactions that they'll have by taking a drug away. So they may worry about symptoms flaring up. While there is a good amount of evidence on titrating doses up, there is less evidence on how to either reduce or stop medication. So you may want to seek guidance with pharmacists or other collaborative partners to help you with this. Some prescribers are actually reluctant to stop medications that was started by someone else, especially if it's a physician specialist. But you may want to just pick up the phone and talk to that person or someone else of equal knowledge. Explain your rationale and why you think you want to perhaps pull back on some of these medications and get their opinion and support. Patients often perceive when you start to talk about taking medications away that either their care is going to be inadequate or that you're giving up on them. So communication is key. Having the discussion about best care and best options and harm versus benefit is often enough to counteract this barrier, but you need to be open and honest and involve them in the decision making. So there's a simple stepwise approach to doing deprescribing. Assess the need, prepare your patient and their caregivers with education and information, prioritize which drugs you want to deprescribe, and taper if necessary as opposed to stopping them right away. Make sure you have a plan in place to monitor the effects of this change in prescribing and document after each step so that your team members know what's going on. So in summary, here's some tips to consider if you think deprescribing is the best option. Thorough medication review is essential, so you may want to do the brown bag approach. Have patients bring in their prescribed medication as well as all the over-the-counters, herbals, everything that they take, and line them up by diagnosis. You immediately may start to see duplication or interaction potential, and that can be a good way to start. You may want to stop, taper, or switch medications that lack good indications or have more harm than benefit. It's important, however, not to make too many changes at once because you may not know which actually caused the best improvement in patient symptoms. Have a plan in place to assess after each change is made, even if it's a short visit to check on symptom management. And this is a good time to explain and reinforce the rationale for these changes with your patient and their family or caregivers. If any medications are missing, it's equally important to start them, but be careful and again, consult with your team and your patient when these decisions are made. Here's the resource list I've provided. They're just some samples of articles and evidence that you may find useful tools. Have this discussion with your preceptors and share anything that you find with your classmates in the course. Thanks very much for participating.